So, Brian, I actually have a question for you. Advanced biologics are kind of a hot topic. Do you have somewhat of an algorithm on when you decide to move on to something like that?
I do. It really depends on the patient that we're looking at. If we have exposed tendon and bone, there's certain products that we would use to help get coverage over those. If you have a chronic stalled wound that may have not been healed with your basic offloading vascular assessments, you may look to these advanced biologics after 4 weeks of non-healing to be able to kind of help boost the healing process. But if you're not doing effective offloading and if you're not doing effective evaluation of vascular management, all these things are going to go to waste.
Can I ask Dr. Pena, Dr. Shishabor? We had a conversation recently in the department about whether or not you actually send back referral letters or you send back something through the EMR, and how many pieces of paper come across everybody's desk. And my understanding is some folks are, some folks aren't. Do you guys send letters? Do you send things back to your referring?
Yeah, we send letters, and letters if you come to the office. If you're seen in the hospital, it goes back to, you can have them so they can get a copy of your note. I find those the letters, I don't know how effective they are. I think they're more effective. I think the EMR stuff, I think, is not effective. I mean, people are signing off on hundreds of things a day, so it makes it very difficult. I think the best thing is, like you recommended, picking up the phone, calling, or texting. I find that is my #1 communication. I try, every patient, regardless if it's a CLI patient, any type of procedure we do, we have, basically instructed the fellows that we're going to make sure we contact, not only go see the family, but right after that, call the referring physician and let them know what's going on with their patient or their patient that we're managing with them. And then I think something that you said that's really important that hopefully people did not lose is the communication of what happens afterwards. And I wrote down here, basically, we finish our report, we have a plan, but I think it's important to say inline flow, the right angiosome, or tenuous runoff. I think that's really important because you manage the expectation of the patient as well as the next step. You may decide, okay, I'm going to take them to amputation sooner rather than later. You may say, at the level, we've been called to the OR many times, which is what we love, is, hey, we're about to do amputation, and we'll go down to the OR and watch to see what's really going on. Because I think that's really where you start creating those bonds and that communication. All right, if I took too long.
I would just add one thing. I would reiterate the phone call, because I think not only is important, as you mentioned, Tino, that you can communicate what happened during the procedure, but it also opens the discussion for the future, meaning that if the patient follows up with you as a podiatrist or a wound expert, you're comfortable now. You have my number, I called you. You can call me back and say, hey, listen, something is not going right. Things were good for the last 2 weeks, the last 2 months, but now all of a sudden I think we are going in the wrong direction. And I also want to congratulate, Terry, we have over 50 podiatry students right now in the audience. And I think it's great that they're attending these sessions because they're really learning about angiography, revascularization, both endo and open, and understanding what the limits are. So that's going to also help with the communication when we're talking with them. They understand what we're talking about, and hopefully we know a little bit and understand where they're coming from.
Any questions from the audience? Stay there, Brian. All right, Georgianne and Brian, both. When would you lengthen that Achilles tendon? If you've got a plantar neurotrophic ulcer, when? What's the timing?
Well, some would advocate if you're doing more proximal amputations, such as a transmetatarsal amputation, it should be done at that time. I don't typically do that because I've seen enough of these patients not necessarily develop an equinus component. I think when you do your initial evaluation of these patients, if you identify an equinus, which is basically a limitation of motion at the ankle joint where they don't pass 90 degrees, so increased pressure as a patient on the forefoot, that should be in your treatment plan. So as long as that patient's being revascularized, you may want to do it at the same time that you're doing these minor procedures, or attempt some management for offloading and things like that. But the reality is you can do all that as soon as they return to a shoe, even if it's an extra depth shoe that's with special liners, they will ultimately re-ulcerate. So I think that plan should be in place quite early.
Georgianne?
So I'm pretty similar in a lot of the midfoot amputations. I'll combine that with a tendo-Achilles lengthening. It's pretty standardized. In and of itself, I would say there's pretty good evidence that it does have great resolution of plantar metatarsal head ulcers, Mike Mueller did a great study out of St. Louis, Missouri, comparing it to total contact casts with decreased recurrence of plantar foot ulcers. But it is a temporary fix. We know that after 12 months, those pressures in the gait kind of resume. So usually initially I'll start my patients doing stretching exercises. It's not a first-line agent, but it is a good adjunctive procedure, or for that resistant plantar metatarsal head ulcer.
I wanted to ask a question from the panel. Maybe Raghu can take this one and others can comment. In regards to the timing of minor amputation after revascularization, what are your thoughts, Raghu, on that? So after we revascularize, frequently the podiatrists or my wound experts are asking me, when do you think I should go and do it? And I'm kind of asking them, when do you think you should do it? So can you help us out on that?
That's always a really good question. I think there's 2 studies that I know of, and the first study said revascularize first, then amputate. Then in my presentation, I talk about another study that was looking for that answer with transmetatarsal amputations, and there was no difference before or after.
Anything to add to that, Raghu?
No.
Yeah, I always find that challenging. I mean, my own, because of sometimes it's hard to follow these patients. So if they get amputated and leave the hospital, it's sometimes hard to get them back. And then, so I have tended to always revascularize, and sometimes even wait a week or 2. I don't know, Tino, how you guys do it over there, but
You're right on. It's when to do it, and like you said, the follow-up. And I always have these patients, and we're going to talk about it later in the session, is you need to follow them up, and what's the most aggressive way? That's how you have to do it. It's like.
And the other thing, I guess I could add to the question, Mehdi, is the post-interventional, state of the revascularized foot. So that's very important too, and what type of intervention was done, because you want to heal that ulcer before the lesion goes down.
that's right.
So how complex that lesion was is also sort of important. So it's a very difficult question to answer in a trial type of perspective. I think it's more of an art.
I think in a practical setting, at the time of the hospitalization is ideal, because we know a lot of these wounds have been chronic. So the sooner we can get this done and accomplished, the better. We want a shorter duration for ulcers. That's the bottom line.
Do you worry, and I know we have to move on, but do you worry about that post-reperfusion edema and dehiscence and things like that? Because that's one of the things that I think we get into trouble with sometimes, is that you see them back in the clinic, the foot's really big and swollen, they've had a lot of reperfusion, and now you've got tension and things don't go as well as you want.
If I don't mind, we see that fairly often, and sometimes we will kind of delay any podiatric procedure because of that. They may do a light compression wrap if it's feasible for the patient to do that to help reduce the edema, but we may wait, if it's possible, 2 to 4 weeks before we do anything. I mean, a lot of these patients have chronic ulcers. They're coming to us after being treated months and months, so waiting a few more weeks generally doesn't make a huge difference. The concern is that if you have an avascular foot that you're revascularizing, you can incite an infection that way, and so you have to follow those patients very closely, and so that's kind of the algorithm we follow.
And I would add one more thing, because I think it's a great question, is that I would say that the number 1 call to my office after complex intervention is the patient that calls and says, I have a lot of swelling, I'm very worried, something is wrong. Yeah. So they do get a lot of edema, so leg elevation and the things that you mentioned, Brian, are very important.
Can I quickly ask, if we have time, how many of you use hyperbarics if you have a reperfusion injury leading to dehiscence of the wound and that kind of stuff?
In our institution, we don't have access to hyperbaric treatments. I've always viewed it as an adjunct therapy, not a primary therapy. If I have a flap that I'm a little concerned about, we do have a institution that I can refer them to, but that's become much more rare as the evidence hasn't really supported the need for it.
I use it. I use it pretty regularly. I always have a few people doing hyperbaric, and I think the number 1 indication is really someone who's been revascularized. I've probably done some procedure on them, and I just want to optimize their chance of success.